Thank you so much, sir. We'll now move on to the next session. This is the academic session on cardio-oncology and prostate cancer. I invite our chairperson, Dr. Partha Sarthi Roy. He's the professor and head Department of Medical Oncology at Dr. B. Bora Cancer Institute, Guwahati. Welcoming sir to the stage, and I request you to please introduce our moderator and panelists.
Yeah. So, very good morning to everyone. First of all, thank you, Dr. Vivek, and thank you, Purvi sir, for giving me this opportunity. And without much wasting our time, we are going to heading towards an interesting panel discussion on management of prostate cancer with special emphasis on cardiotoxicity. So for that, we have our Dr. Vivek Agarwal. He does not require any introduction to this August gathering. Still, he is our Director of Department of Medical and Hemato-Oncology from Narayana Super Specialty Hospital, Howrah. So without much wasting your time, Vivek, stage is yours. You may call upon your panelist.
Yeah, the panelists are Dr. Deepak Dabkara, who is a senior medical oncologist at TMC Kolkata, Dr. Tarun Jindal, who is a senior uro-oncologist working at Apollo Hospitals, Kolkata. Dr. Maria Tan is the cardio-oncologist and intervention cardiologist at Manila in Philippines. She is joining us virtually. Dr. Anuprita Dadi is our cardio-oncologist specialist. She is cardio-oncologist working at TMH Mumbai. And Dr. Ashish Upadhyay is a medical oncologist working at Fortis in Kolkata. So we just have half an hour to discuss a lot of cardiovascular issues in prostate cancer. So let us very quickly go ahead with the case and have very crisp and specific answers so that we can move ahead quickly. So let us consider this case scenario of a 66-year-old male newly diagnosed metastatic invasive prostate cancer, Gleason 8, with a baseline PSA of 90 and diagnosed with 3 vertebral mets, pelvic nodal mets with a T3B-N1 disease. And patient is a known case of hypertension with 15 years, controlled currently on cilnidipine 10 milligram, and diabetes since 15 years, now controlled on a combination of metformin, vildagliptin. And patient also had a history of an acute coronary syndrome like presentation to an emergency 2 years ago. And at that time, the angiography, echocardiography was normal, but the patient was started on statins, and patient is currently under the follow-up of a cardiologist. Patient was a smoker, but he had left 20 years ago, and he is presented with mild lower urinary tract symptoms, backache. He is 90 kgs in weight, slightly overweight for his BMI, and his performance status is 1. So very quickly, if I come to Dr. Ashish, what is your treatment plan for this patient? It's a metastatic hormone-sensitive prostate cancer, and with comorbidities of hypertension, diabetes, already on medications.
So just because this is a case of oligometastatic CA prostate with low volume of metastasis, so ADT with abiraterone, because I would also keep radiation oncology in the pool, because radical RT to prostate also would be an important component to this patient.
So ADT is the correct treatment plan. And if I come to Dr. Deepak, metastatic patient, of course, there is no role for surgery, but what are those factors that determine survival, long-term survival in this patient? How would you enlist the patient or counsel the patient as to what factors will you take into account when you see the long-term survival?
First is volume of disease, whether patient has synchronous mets or metachronous mets, this cardiac complications.
Correct. So what I wanted to stress here is that the cardiovascular complications have now become really important when you are determining the long-term outcomes of these patients. Patients are going to live for long, and when you look at the all-cause mortality in these patients, there are recent reports that the cardiovascular mortality increases in these patients, and they are probably in some of the reports they are higher than the prostate cancer related mortality. So that is the reason why we need to look into the cardiovascular disease profile in these patients, because the cause of mortality in these elderly patients of prostate cancer is often a cardiovascular event rather than a prostate cancer related event most often. So coming to Dr. Anuprita. So Dr. Anuprita, what do you think, when these patients, when are they at the highest risk of a cardiovascular event when they start the treatment?
It will be early, initially within 6 to
Correct.
1 year.
So the initial 1 month period is something that is, the initial 1 year period is something that is very, common, because if the patients, they have an event, the events tend to occur in the first 1 or 2 years rather than, occurring
Yeah,
later.
I would also like to add that these treatments are long term. When oncologists plan the long term treatment, considering your patient might be low risk to begin with. But if you don't, and all the guidelines speak about baseline risk assessment, but in our clinical practice, my experience is you can't just go on baseline. You have to reevaluate this patient again and again and assess the risk again. Because intermittently, with these drugs and all, you will have those CV risk factors coming up, your dyslipidemia and all this thing. And that's why it is very important to keep a close watch over the year and long term.
Correct, correct. I totally agree. So I'll come to Dr. Tarun. So Dr. Tarun, when you see these patients in your practice, how many of these patients do you see to commonly have cardiovascular disease already existing at baseline when you are seeing
So I would say, because by the virtue of CA prostate being a disease of elderly, I would say majority of my patients, more than 50 to 60%, have a pre-existing cardiac disease or vascular disease or neural disease of different kinds. If I go to diabetes and blood pressure, I would say 80% of my group, even more than that. They are already having a pre-existing hypertension or a diabetes. So, all these factors do need to consider, because 2/3, by and large, will have either one or more of these factors.
Great. Is Dr. Maria Tan available on Zoom? Ma'am, you're there?
Yes, ma'am. Yes, sir.
Yeah. So Dr. Maria, can you just sort of elaborate what is the mechanism of cardiovascular toxicity with these androgen deprivation therapies?
So with these kinds of therapy, I think for prostate cancer, we know that it affects older men who inherently already have a higher CVD risk. So in my practice, all of these patients indeed have concomitant CVD, and the mechanism for this is with this risk of adverse cardiovascular outcomes, especially with ATP, is thought to be related to its role in promoting atherosclerosis, dyslipidemia, adiposity, and insulin resistance.
Yes. So when you look at these cardiovascular toxicities of androgen deprivation therapies, so Dr. Ashish, you talked about adding agents like abiraterone, and there is even data to add other androgen receptor pathway inhibitors. So is the cardiotoxicity further increased? Are you more sort of concerned about cardiovascular events happening?
Definitely, sir, because it can also increase the chances of hypertension and other, even there are, as per the European Society of Cardiology 2022 guideline, they are associated with increased cardiac risk as well. So definitely, yes.
So,
So I'll make it a point. So, the robust data for ARPIs in a low volume disease with abiraterone. Abiraterone is not given alone, it's given with the steroid. So you have to also consider the morbidity added by steroids. So, a lot of things go into your mind once you recommend these medications.
So we all have elaborated these points. The risk of increased cardiovascular disease with ADT is unquestionable. We have all said there is even an FDA black box warning regarding the leuprolide that it increases the risk of sudden cardiac death and stroke, and with all forms of ADT there is increased cardiovascular disease and events. Dr. Maria just told about the mechanisms, and it is not just related to low testosterone, but there are drug-related effects on the process of atherosclerosis, as well as increased risk of atherosclerosis. Now, this is the age-old debate that is there. That is there a difference when we talk about putting our patients on antagonists, GnRH antagonists versus GnRH agonists, when you talk about androgen deprivation therapy. So, Dr. Tarun, what do you think? Suppose a patient comes to your practice, what is your preference when you talk about agonist versus antagonist, and how do you decide?
I mean, if the patient has pre-existing significant cardiac issues, my go-to drug is an antagonist because, I mean, all said and done, we have good data available which says that as far as the MACE or the cardiac events are considered, antagonists behave better. So now amongst the antagonists, that can be a debate on what antagonist you're going to choose. But yes, I mean, these patients, I would probably prefer an antagonist as compared to an agonist.
Okay. And Dr. Deepak, you know, if patients, if it is preferable to start patients on antagonist, do all patients you start on antagonist, or is there a criteria? You know, some patients where the agonist might do as well, and you select your patients, go for agonist.
Patients who have pre-existing cardiac disease, I will prefer antagonist in them. All other patients, I will prefer agonist.
Okay, I think the choice of ADT is very clear. Now, I'd bring Dr. Ashish. So, your patient already has a cardiac disease, and the patient is on the follow-up of a cardiologist. So, how often do you, bring in your cardiologist in this decision-making process as to what treatment you should give? Is your cardiologist involved when you are prescribing ADT or androgen receptor pathway inhibitors? How does it go about?
So basically, cardiologists are usually not involved in our cases.
Not involved, yes. So, Dr. Tarun or Dr. Deepak, how is it? Do you involve your cardiologist before sort of putting them on these drugs? Because we've already discussed that these drugs have cardiovascular implications, and these patients are already on follow-up of the cardiologist.
Right. So majority of the patients who are we are even thinking about the choice, they are already under surveillance with a cardiologist. So we just make a point in our OPD prescription that you have to tell your cardiologist that this particular medicine has been started, and he might like to tweak or maybe follow you more intensively as compared to the one he was following you earlier. You might require an increase of the medication, but that decision is to be done with the cardiologist.
Okay, Dr. Deepak, what is the scenario?
So most of the patients are already under supervision of a cardiologist. But when I start the treatment, I tell the patient that go to your cardiologist and inform him that we have started ADT and these drugs.
Yeah, Dr. Anuprita, what is the practice in TMH? So in TMH, are you involved in this decision making whether the patient needs to be which drug, which ARPI or which ADT is the patient needs to be started on? Are you involved in this decision making?
Yes, being a cardio-oncologist, now we have a cardio-oncology clinic, and we have a multidisciplinary team involving oncologists and intervention cardiologists too. Now, when it comes to a low-risk patient, obviously we first is we carefully assess the patient. It is detailed assessment of the patient which is required, where you assess the risk of the patient. If it is intermediate to high risk patient, yes, a cardiologist intervention, what we can do for optimization of the risk factor. And on top of that lies, basically important lies is patient's education in giving all this risk which will be associated and optimizing all the risk factors, your metabolic syndrome, etc.
Correct. Dr. Maria, what about the practice at your center? Is these treatments decided by the oncologist and you just follow them up, or you are involved in an MDT where the decision is taken for what kind of treatment the patient is on?
Yes, in our institution, unfortunately, more often than not, we are not involved with the treatment option. They will just refer to us once a patient is high risk. Usually, cardiologists are really underrepresented in MDTs for these prostate cancers. I think it's the urologist may be unaware of the importance of cardio consultation before ADT initiation.
Yes. So I think the concept that yes, an antagonist does really show a difference in decreasing the cardiovascular events, in decreasing major adverse events, as well as in decreasing cardiovascular mortality is definitely there. This is one of the recent meta-analysis that has shown that degarelix is associated with a better, outcomes, and it is not only better oncologic outcomes, faster PSA response, but also decreased cardiovascular events. And these are the studies. So except the PRONOUNCE study, which directly compared degarelix with leuprolide as to the major adverse cardiac events, which was the primary endpoint of the study, all the other studies, the Margell study, the Albertson study, and the HERO study, the recent HERO study on relugolix, clearly showed that there is a marked decrease in the number of cardiovascular events as well as cardiovascular deaths. Now, and this is one of the retrospective studies recently on relugolix, where also they have shown that antagonists do offer an advantage over the agonists by reducing the risk of cardiovascular events and death. Now, there is still some discrepancy in data when we discuss all this. So, Dr. Deepak, is there still a controversy, and how do you see about this discrepancy as to why some of the trials have not shown any difference in the cardiovascular diseases and mortality, but there is the HERO study which has clearly succeeded and in a prospective completed full trial shown that yes, the cardiovascular events are lesser with antagonists.
I think still there is controversy. It cannot be proven 100% that antagonists are safe and agonists are bad. I think there is still controversy. Retrospective studies show that antagonist is better. This PRONOUNCE trial could not answer clearly because there were less patients accrual, and this HERO trial, it was a secondary endpoint. It was not a primary endpoint. So 100% I can't say that antagonist is better.
Yeah. What about you, Dr. Ashish? What is your point as why did the PRONOUNCE study fail, but the HERO succeeded and there was a difference?
So basically, the events were less with PRONOUNCE. So it was the primary endpoint was MACE, so there was strict cardiovascular care with that. Just because the events were less, so it was underpowered. So that was the main reason behind it.
Correct. So what was there in the PRONOUNCE was that MACE was the primary endpoint, and because the primary endpoint was a cardiovascular event, there was a protocol mandated strict cardiovascular care that was already there in both the arms of leuprolide as well as degarelix. So that is why, even though the cardiovascular morbidities were very equally distributed in both the arms in the PRONOUNCE, but the actual rate of cardiovascular events was very low in the PRONOUNCE study, and that was the reason why the trial was also closed early. They couldn't complete the total 900 patients, and it was an underpowered study. So this is one of the major study, but HERO probably it was a very complete trial. It achieved all the endpoints, and even though the adverse cardiac events was a secondary endpoint, the study was still powered to detect any difference in the cardiovascular events, and that is the reason why I think the HERO study probably is the final nail in the coffin, which sort of very clearly establishes that yes, the cardiovascular safety is undisputably better with the antagonists. Now coming to the choice. Now as soon as what I see is that relugolix oral treatment is available, I see a flurry of prescriptions with urologists and medical oncologists, and more so urologists, writing relugolix to each and every patient as compared to you. So I'll bring in Dr. Tarun. Dr. Tarun, how do you sort of make a choice in your clinic? Is it like an oral relugolix for each and every patient, or how do you make a choice between antagonists, the relugolix and the degarelix?
Right. I fully agree with your point that relugolix has become an epidemic now. It's a drug like paracetamol, which is being used left, right, center. Anybody and everybody is writing as soon as the cancer prostate is getting diagnosed. Now this is becoming a nuisance actually. As far as the criteria goes, we generally give both the options. As far as the validity, the data available, both the drugs have been tested in the scenarios in which we want to use them. But we give an option saying that this is an injection and this is an oral formulation, whatever you are comfortable with. And what I've observed that degarelix initially causes slightly more injection side effects, so patients do tend to ask us for alternatives. In that scenario, we shift to relugolix. But yes, during the first discussion, it's always both, that these are the things available to you. You can select either of the ones.
Yeah. Dr. Deepak, if I may ask you, what is your practice, and which are those patients where you go for degarelix and which are those patients where you would prefer relugolix?
My preference is relugolix because it's an oral drug, and if the patient is compliant, I ask the patient whether you will take that drug daily, and if the patient says that I will take medicine regularly, then I prefer.
Yeah. So there is an issue of compliance. Okay. Yeah.
I'll add a point. So as far as the hero goes and the recommendation pamphlet which goes with relugolix, even if you miss a dose, there's no need to actually panic. But what I have seen, the amount of responses which used to happen with relugolix versus, I mean, the PSA definitely drops. But I think the hits and misses are more in relugolix because the patients do not admit that, but they tend to miss it repeatedly. Possibly that's causing the PSAs not to come down to that level which we want them to.
Correct. So outside of a trial setting where you are not very sure of a compliance, I think there is one issue regarding relugolix. What about drug interactions, Dr. Ashish?
So basically, talking about relugolix, another important point is that the testosterone recovery is also early with relugolix. So for me, the drug of choice is always degarelix. Only if the patient asks for an oral agent, then only I go for relugolix. In my case.
Yeah. So I think it also the testosterone recovery is early. So maybe if you are missing 2 or 3 doses, then you may see an early failure, and that is one of the risks involved. What about the mechanism? Why antagonists actually show less cardiovascular events? Dr. Maria, would you want to comment? Because it's an ADT for both the antagonists and agonists are a form of ADT. But why antagonists are showing less cardiovascular events?
The reason why GnRH antagonists are associated with fewer cardiovascular events than GnRH agonists primarily because they do not actually cause this initial surge or subsequent microsurges of testosterone and consistently suppresses the FSH. So I think that's one of the reasons why we don't see them as much as for GnRH antagonists.
Correct. So this is like a lab study where they looked at the FSH levels after giving after orchidectomy, after degarelix, and after leuprolide, and what was seen is that the FSH levels was actually lesser in the degarelix treated mice, and there was the atherosclerotic plaques are lesser when you have FSH. And what is seen is that this sustained. So if you look at the time and timeline as to treated patients with degarelix and leuprolide and the FSH levels, what you see is that these are similar till around half a year, around 200 days. But as you go on later in the year, you see a sustained decrease in the FSH levels with the degarelix, but with the leuprolide, you see that the FSH levels are still higher and maintained. And the FSH receptors are actually there on the endothelial cells of your coronaries. And that is the reason why these FSH receptors are able to induce more atherosclerosis. And that is the reason why you have more atherosclerotic events associated with antagonists rather than the agonists. We discussed this, and yes, drug interaction, compliance, adherence, these are all practical problems with oral relugolix. And then there is sudden surge of multiple generic brands. There is also a question of reliability, and that is the reason why, at least in my clinical practice, for my high risk patients, I would want to start them on degarelix initially, and then maybe shift them to oral component when their disease is really well controlled. Unless they are very, very keen on an oral option. Let us come back to this case scenario, and Dr. Ashish, what about a baseline evaluation before proceeding for treatment? So do you go for a baseline evaluation in all your patients regarding the cardiovascular parameters before you start your androgen deprivation treatment?
Sir, definitely yes, sir. Because most of the patients are elderly. So baseline sugar, HbA1c, routine lipid profiles, ECG, cardiac, even cardiac markers are coming in a big way, being routinely evaluated in prospective studies as well. So this baseline assess, apart from that, BMI also is very important for these patients.
Dr. Dabkara, so what about this risk assessment? Do you do a formal cardiovascular risk assessment, and what method you use for your cardiovascular risk assessment?
So we do routine ECG, echo lipid profile and blood sugar, but other than that we don't do any routine.
So you don't do a documented like a risk stratification, but at least you do this.
Baseline.
And how do you identify your high risk patients? Which patient do you say that no, this is a high risk patient, and no, this is a low risk patient?
So if the patient is already having some cardiac event, CVA, and then we consider them as high risk. Otherwise, suppose the patient has only hypertension controlled, then I don't put the patient in that high risk.
Okay. And you refer all patients to your cardiologist, or you select that which patient needs to be referred to cardiologist when during their follow up and treatment?
I don't refer all patients. Selective patients I refer.
Okay. So, so this is the the ESC position paper that came out in 2020 on the baseline cardiovascular risk assessment, and for ADT, even this study showed that more than 30% patients even in the United States didn't get a formal cardiovascular risk assessment. What is recommended is just as everyone said, the HbA1c, the fasting lipid profile, echocardiography, which is more mandatory for intermediate to high risk and those with history of cardiovascular events, and cardiac biomarkers is something that is probably optional for the high risk patients. And this is the ESC guidelines on the risk factor assessment, where they have given different atherosclerotic related cardiovascular risk calculators, and based on these risk calculators you can classify patients objectively into whether they are in a high risk, intermediate risk or low risk based on their cardiovascular disease 10-year risk score. So if it is more than 20 they are high risk, 10 to 20 they are medium, and less than 10 they are low risk. And if you look at this patient, this particular patient, so this patient had a blood pressure quite controlled on the clinic, but his cholesterol was 190, LDL was 110, HDL was low, 35, diet was controlled, sugars were controlled, patient was on statin, and aspirin was not on aspirin. So this is the ACC cardiovascular risk calculator, and based on this, what was found is that the 10-year risk was 33% of cardiovascular disease, and this patient actually fell in a high risk, even though he didn't have. And this is one of the initiatives by Ferring, where they have looked at the PCCV group, which is looking at the prostate cancer cardiovascular expert network, and they have also come out with this paper which has recommended what cardiovascular disease risk assessment and multidisciplinary care has to be taken into account when you start these patients on ADT. And they have suggested a very simple way of identifying the high risk patients, just as Dr. Deepak said, that if there is any of the events, cardiovascular events that has happened, like a stroke or unstable angina or a transient ischemic attack, MI, or intervention for a coronary disease, then these patients are high risk. And if these are not there, and patients have any of the cardiovascular risk factors like diabetes, hypertension, dyslipidemia, then these patients are intermediate, and if none of these are there, then these patients are low risk. And Dr. Anuprita, how does the treatment change when you and the monitoring and the follow-up change when you talk about low risk versus an intermediate risk versus an high risk?
So basically, as I said earlier, it is primarily the ABCD. Like you do assessment, you start aspirin wherever is possible. BP, the B is for systemic BP control. C is for cholesterol lowering and cessation of smoking. D is for diet and diabetes, and E is for exercise. So the patient has to be educated throughout and kept into consideration when you are giving any cardiotoxic chemotherapy or any treatment you are going to start. So there has to be a regular assessment of the patient along with education. That's what. And you start all the guideline directed medical treatment wherever indicated.
Dr. Maria, anything you want to add regarding what interventions do you take into account when patients are referred to you for improving their outcomes?
For me, we cannot overemphasize also the importance of cardiac rehab for these patients. We want to improve outcomes for prostate cancer. Of course, it involves a combination of appropriate medical treatment, healthy lifestyle such as diet and exercise, and a strong supportive care. And I think the also we need to manage the emotional and practical aspects of cancer because this is really vital for overall quality of life for these prostate cancer patients.
Quite valid points. Yes, so in low risk cardiovascular disease, formally, the guidelines all suggest that yes, GnRH agonist is may be used, but for all intermediate as well as high risk patients, I think now all the guidelines do say that we should go for an antagonist only. Very quickly, just last 1 minute, when you talk about androgen receptor pathway inhibitors and the cardiovascular risk, so now we have multiple options like abiraterone and the three androgen receptor inhibitors. Yes, sir, you want to ask something?
On the previous slide, when you said high risk, intermediate and low risk, where does the orchiectomy fit into this? One. And second thing, we have antagonists for last 3-4 years. Before that also we used to treat intermediate and high risk with agonist and orchiectomy. So I would like to know, where does the orchiectomy fit into this?
Yeah, I think it's a very valid question, and maybe any of the panelists want to take into this. Dr. Tarun? So where does orchidectomy fit into this risk stratification model?
Orchidectomy, there are conflicting data is available saying that orchidectomy may be better, orchidectomy is at par. So what I personally quote, if there's a discussion, I always quote a study meta-analysis by Xiong et al. Which was published in 2000. So that categorically tells us that orchidectomy is at par as far as the efficacy goes and the side effect goes to any kind of antagonist or agonist. So yeah, so I would probably, for intermediate and low risk, I would be certainly offering them orchidectomy. For a high CVD risk patient, again I will discuss whether it's a financial decision or it's a practical decision. So if it's a financial decision, then orchidectomy, yes, I will definitely discuss orchidectomy for him. If it's a decision which is off the finances, then I think obviously the choice would be towards an antagonist.
So what my feeling is that, sir, that the number of orchidectomies have decreased, remarkably when you go to the West, and that is the reason why when we are looking at the bringing in orchidectomy into this, so the incidence of orchidectomy or the rate of offering orchidectomy has decreased so much that is the reason why it doesn't come into the discussion when you talk about this.
So there is orchidectomy analysis has been done.
Yes.
My point is that if you see the 15 years of meta-analysis, in fact, and we are a medical oncology conference, orchidectomy is a shade better than antagonist and agonist in terms of efficacy. And the second thing is, first 1 month of post-orchiectomy, when the sudden drop in testosterone happens, FSH increases, first month of cardiotoxicity is as much as agonist. And then it drops to antagonist. So my point is that, you are a neurosurgeon, right? My point is that if the patient is high risk and if there is a financial problem, will you hesitate to do orchidectomy? That is what you would.
I would not.
Yeah.
One thing I want to just add is, most of the cardiologists are not aware that the ADT is associated with high cardiovascular events. In fact, those people who do not have any risk factor can develop that within the first 3 months and can land up a cardiac event in 6 months' time. So all of them must be treated. And one point you said is very, what all you do. In that, please note that there is no stress test. These are risk factors which you have to look
stress.
at.
I think the stress tests and all interventions are actually for the high risk people who are actually symptomatic, and that is actually based on symptoms what cardiologists will offer them. But so last just one discussion as to among these molecules, abiraterone, enzalutamide, apalutamide, and darolutamide, what is the sort of which one is the most cardio safe as per your practice, and in your high risk patients, how do you choose among them? Now you have the choice of all of them you can offer in a HSPC.
I think darolutamide is the safest if the patient is not on rosuvastatin, and second will be enzalutamide. Abiraterone has the highest cardiotoxicity.
Yeah. So I think but this is something that the data is not very clear, but I would say that yes, darolutamide probably is ranked as one of the favorable ones. Enzalutamide probably has the highest incidence of hypertension, and apalutamide and darolutamide, yes, there might be a good discussion as to efficacy and the cardiovascular toxicity. But enzalutamide definitely comes as one which has the highest incidence of
So I think
hypertension
that should be the
and
take-home
toxicity.
message,
Yes.
Vivek, because in the meta-analysis and in the cross-trial comparison also, hypertension is the only caveat with enzalutamide, but amongst all four what you have listed, it has been noted to be the most cardiac safe of all RPs.
Yeah. So, sir, another point is also regarding abiraterone is that yes, it has an extra mineralocorticoid increased toxicity. You have to use steroids along with. So definitely in your patients who have high cardiovascular risk, you should try to sort of use apalutamide or darolutamide rather than using abiraterone or enzalutamide. And yes, in the Spartan study and all, there was an analysis which showed that addition of statins does decrease cardiovascular events, and this is something that should also be used with those androgen receptor pathway inhibitors. That yes, addition of statins is something that we should look into. So with this, I thank you all for patient listening, and yes, sir wants to make a point, so maybe after that we can close this session and move to the next.
Yeah, I believe so that for all the patients where you start this therapy for prostate cancer, it is not necessarily mandatory that a cardiologist should be involved right at the very beginning. But certain patients, obviously, the time we are doing a real check for any cardiovascular diseases, and all patients who are like a low normal LVA for the GLS is reduced, which we'll be talking about later in the day today. In those particular patients, definitely a cardiac involvement would be required. But I don't think so that, like, there was a question that when would you really require a cardiologist to be involved? So at the inception of therapy, it is not necessary that a cardiologist be involved.
Thank you. Thank you all.
Thank you, Vivek, and thank you all the panelists.
What do you take of this paper? Is it going to change the way you look at CDK4/6 inhibitor?
See, as far as the three CDK4/6 inhibitors are concerned, as you are right, in elderly patient, if you want to say the cardiac safety profile, probably palbociclib must be the most safest drug. Whereas on the contrary, abemaciclib is associated with more and more incidence of VTE. But seeing this paper with more than 7,000 popular patient having this much of toxicity, definitely I will be very much skeptical in advising palbociclib from tomorrow onwards.
Pandey sir, this paper is in front of you.
Yeah, I really wanted to ask you because you have gone through this. How it was adjudicated, myocardial infarction, what was the criteria in this paper?
So sir,
it was enzymatic rise, ECG changes.
How the FDA adverse event reporting system happens is that it is an acute event, what you are supposed to report. So you miss out on chronicity, you miss out on comorbidities. If it is written, it is written. If it is not written, because that is few drawbacks of this particular paper. So all the acute events which are reported on the system or on the website is what is taken. So if you ask me the details of the symptoms and all, right now we don't have in this paper, but if you see myocardial infarction, cardiac disorder, atrial fibrillation, palpitation, cardiac failure, they have written everything.
Because as a cardiologist, I can tell you myocardial infarction, unless they follow the guidelines, is most likely a vague one.
So US
Rise in troponin I with non-obstructive coronaries are pretty rampant. And with the use of high sensitivity troponin, we daily get this troponin 200, 3000 get referral from intensive care, coronaries are normal. So I think we have to follow the
we have to take
paper
it.
in
You are saying
detail.
that we are taking with a little pinch
Unless
of
there is
salt,
a causal, so in the medicine you have to prove it is the causal mechanism or not. If not, you can't explain, you can just brush
I
it
take
on.
your point, and I'm sure, sir, the paper, I couldn't see the definition of myocardial infarction because that is not probably which I wanted to look for that, but I will go through it and get back to you. Yes, sir.
So, Amish, there is some literature reported there is an interaction between the CDK, CD4 and PPIs.
Yes,
so
especially lansoprazole.
Yeah, it definitely reduces the efficacy.
Very common. Yeah.
It reduces the efficacy but also increases the chances of MI.
So lansoprazole, they say QTC prolongation along with CDK4/6. What I read, sir, but I think
So
I'm
not
sure
using PPIs with TKIs.
Okay.
I'm mainly going for the H2 blockers. I don't know what others.
But I don't know about vonoprazole, which is once a day, new PPI. I think it takes care of QTC. The vonoprazole is a new PPI, once a day, not related to food. In fact, gastroenterologists have changed their practice to vonoprazole now. So this is something, but your point is right. And there's a very interesting another finding that median time to hypertension, if you see, which was just 30 days with ribociclib, which is there. Dr. Roy, how frequently you check? Every time the patient comes to you, obviously the vitals are taken. But do you tell the CDK4/6 inhibitor patients to take BP regularly at home?
At least once a week, not that regular.
Once a week.
At least once a week, recording.
In your busy practice, you have a time to look at those once a week.
I am not looking personally. I just wanted to ask the patient to record their BP weekly, so that in the every visit they are coming to me, they are coming with the reports.
Right. Okay. So we'll move to the second case in the same this thing. 42-year-old female. And this is very, very interesting. C-T3N2 disease, HR positive with 6 lymph nodes, grade 3. Treated as per standard guidelines, adjuvant abemaciclib based on monarchy was given. After 2 months, she complained of sudden palpitation. BP was 140/90. Her baseline BP was 130/80, 120/70, but never like 100/70 or 110/60 like that. ECG echo normal. Now GLS was minus 17%. Dr. Munna Das, your take on this particular slide.
Yeah, so the EF around 55%, as you mentioned, is normal with the GLS borderline, means it hasn't dropped to minus 15.
What is GLS, normal GLS in your practice, sir?
Normal GLS will be something more than minus 18%.
Minus 18%, okay, right. So this particular patient, does this patient have, and based on this slide.
Any halter or something done for this
halter
patient?
was done, sir, halter was negative.
And the baseline ECG not available?
Baseline ECG must be available because before any CDK4/6 we give, I'm sure it must be normal because otherwise I would have mentioned. This is a real case basically, a very, very interesting first in my career.
Okay.
So this Dr. Ray Chaudhary, based on this particular slide,
I mean, the GLS, I think.
minus 18 ले लो. Sir ने बोला minus 18 normal है, तो let's take minus 18.
So it's less than that. So there is some kind of asymptomatic decline in
some
the GLS.
kind of asymptomatic. So assuming GLS is minus 18, then
it would still be normal only. Sir.
Then it would be normal. Okay. So my cardiologists, they say 17, 18 is normal, and that is what it was there. Pandey sir, you also mentioned about GLS when you were chairing the session.
So
is it the earliest sign of cardiac dysfunction?
Absolutely. And regarding the value, you have to be sure which vendor you are using in your hospital, because the GLS value varies from vendor to vendor.
Okay.
For someone it will be 15, for someone it will be 18, whether it is a GE, Philips. So you have to sure about the.
Dr. Nihanti, are you taking GLS deciding cardiotoxicity for your chemotherapy or trastuzumabs or CDKs of the world?
Sir, to be really frank, prior to this conference, seriously I'm telling, actually I read about GLS recently. So I was only looking at the EF. Maybe then if patient was more than 60 with comorbidities, then I would look into all the parameters. But yes, after reading this, I would consider now, sir.
Now
prior I was not.
Alurkar sir, are you using GLS in your practice for deciding the dose or interruption?
So any patients on IOs or TKIs or TEs or GLS at baseline, all patients identical.
Right.
Then every 3 months they need to work on.
So if the ejection fraction is 60%, but GLS from minus 18 has dropped to minus 15, will you interrupt your drug? Minus 18 to minus 15. So this was the review. Let me.
It's not an indication at all. The GLS-based interruption of therapy alone is not indicated.
Yeah.
It is not clinically meaningful at all.
Right. Okay. So anyone in the panel agrees with sir?
Actually, there is a concept of giving a breathing period vis-a-vis complete interruption of therapy. So point is, like, if you have, so you have to have some check thresholds. Okay, so you cannot allow your patient unknowingly to go into overt heart failure. So if you have a drop in GLS to like anything below minus 15, then you should be cautioned. You should actually
we know the
upgrade.
dysfunction is coming.
So,
Dysfunction might come,
I think
but
the
it does not stop medication.
No,
Right.
we are not
Treatment of
asking you
cancer
to
is
stop
more
it,
important.
but you should be cautioned.
Sir,
Yeah.
I think what he's saying is right. In that review paper which I gave, they said that the GLS alone is just an indicator. Don't do anything, don't act only on GLS, but GLS with TROPI or GLS with anti-pro-BNP, the sensitivity and specificity touches 90%, sir. So if your GLS is low, I think then we should go for biomarker, and that's where we do. So this particular patient, what did we gave some antihypertensive, tried to control, because 140/90 was just starting of hypertension. Palpitation continued, and the highest reported heart rate was 140. ECG echo remained okay. Cardiologist said, Amish, palpitation and anxiety ho sakti hai, let's add beta blockers. 3 months later, we continued abemaciclib. 3 months later, GLS is minus 13%, anti-pro-BNP is 450. We did not do baseline because 42-year-old patient, we never suspected anything. Now, Dr. Ray Chaudhary, should we start doing biomarkers if we are doing GLS from tomorrow in every patient baseline?
So, I mean, looking at this paper, it appears so, but in practice, I don't.
Practice you don't. Okay. Pandey sir, what do you do now? See, 450 is anti-pro-BNP current. We do not know the baseline.
So for anti-pro-BNP, there is a set guideline from European, American. If whether you are in sinus rhythm or AF, and based on your BMI. This is probably AF, so cutoff for AF is 500 and above is bad.
So ECG was sinus rhythm.
No, he said heart rate 140 cannot
Heart rate
be
was
sinus
140,
rhythm.
yeah.
It,
No, sir, palpitation mein reported highest heart rate.
Okay.
According to patient was 140.
so considering if it is sinus, this is
It is
abnormal.
sinus, sir.
So cutoff
this
is
is
250, 500, 1000. So anything above 250 in sinus rhythm with BMI less than 35 is bad for me.
Okay, perfect. So this is what Dr. Niyanti, Dr. Pandey sir has given you this feedback. What will you do in this patient now?
Sir, so even I have the same query, sir. If patient is doing good on abemaciclib, currently she's symptomatic. In case she was asymptomatic, would we still want
Your
to?
gold standard was eco in your practice.
Yes, sir.
Eco has been normal all throughout.
But
Would
now
you
looking
stop
at this,
abemaciclib? I will move forward. We have 12 minutes left. Palpitation didn't stop in this particular patient, and anti-pro-BNP increased GLS from -13 to -12. We finally stopped abemaciclib, and everything settled, and patient became okay. So this was my first case of palpitation with abemaciclib, echo remaining normal, ECG remaining normal, but GLS and biomarker helped us saying that there is a cardiac event happening with abemaciclib, and which was there. So we'll go to the second paper, cardiotoxicity with HER2 directed as a meta-analysis. Dr. Niyanti and then Dr. Partha Roy. Dr. Niyanti, we use so many drugs. I have still not used niratinib, margetuximab, कोई एक patient अभी लेके आया है, but I have not used. So out of these, which one is the most cardiotoxic according to you? Name just one drug.
it's a combination I would consider, sir.
Combination you would. Combination of Tras2 with PER2, Tras2 with Lapatinib,
So even Tras2 with Lapatinib combination.
Tucatinib, Tras2 and Capecitabine, will that be the most
Sir, now even
cardiotoxic?
Tucatinib has cardiotoxicity.
Okay,
So
okay, right. So, Dr. Roy?
I think combination of Trastuzumab plus Pertuzumab is not added any cardiotoxicity over and above Trastuzumab.
Okay. What is the most cardiotoxic according to you?
Trastuzumab.
Trastuzumab. Dr. Vivek? Trastuzumab alone. Siri sir, you agree with that? Okay, perfect. I think this is what I agree with everyone what they have said. Still, trastuzumab remains number one cardiotoxic as far as incidence is concerned. Addition of pertuzumab has not shown to be much this thing. TDM1 is the least cardiotoxic amongst all, and TDXD, the recent meta-analysis show 0.2 to 1%, so probably it is further less cardiotoxic compared to that. So with that we will come to one more case. So it's a 57-year-old female, breast cancer, CT3N1, HR negative, HER2 positive, IHC3 plus FISH positive, let's put that. Neoadjuvant Phesgo, I am using the word Phesgo because subcutaneous, there is no other brand available, but plus chemotherapy, followed by surgery, followed by RT, and followed by maintenance Phesgo. Every 3 monthly echo is what I have been doing till now in my practice. After 8th maintenance, showed LVEF of 50%, baseline 56%, anti-pro-BNP and TROPI negative. Cardiologist said, this is just one observation. Dr. Vora, you can decide to continue. If you see 56 to 50, it is more than 10% drop in LVEF. Dr. Niyanti, will you stop trastuzumab at this point?
no, sir, I wouldn't stop trastuzumab.
You wouldn't stop
no,
trastuzumab. Okay. At what point of time would you asymptomatic and say LVEF is 45%?
So if there is a drop in baseline more than 10%, or even if any
This
of
is 10.6%.
so then, so I would still wait, sir. I wouldn't.
You wouldn't stop.
I would look
If,
into other markers.
if LVEF is 48%,
So I would stop.
then you would stop. So magic figure of 50 is required.
No, sir, but at least now currently, because these predictive biomarkers are available, especially when there's a dilemma, I would get the pro-BNP
Dr.
levels.
Sujit, what is the, in ACTRAC, what is the policy?
So we actually do the same thing. We wait till the EF is 50%, or the 10% fall is there.
So this is more than 10%.
More than
fall.
10. But in this case, we would like to continue the trastuzumab as considering the long-term survival benefit with the trastuzumab for the patient.
Pandey sir, कुछ और हमको help करो. I am asking you, कि sir, very precious this thing, patient is cured of cancer right now. All we are doing is maintenance. Please sir, help me decide whether heart is normal or not.
As I said, there is a variability in the assessment of EF. If you want
Sir,
to be
you have done the 2D echo and it is more than 10% drop.
if you want to be purist, just do a MR. That will give the accurate
MR.
picture of EF.
Dr. Mudna Das, how frequently you do MR or you suggest MR in cardio-oncology patients?
If there is a divergence between the biomarkers and echo report, then only we do.
Then only.
Cardiac marker?
Yeah.
Give you a cardiac MR to give a volumetric analysis of
Yeah.
the
And you have to see that software is there in hospital. They do a T2 mapping of extracellular volume and all.
So rather than going for MR, would we have 3D derived machines right now? So the comparable EF can we get, we can get a 3D derived EF
From
also.
the 3D. Okay.
Yes.
Why don't you treat heart failure?
Sorry?
Why don't you treat its cellular dysfunction and keep continuous therapy which
So
cures cancer?
I'm asking because just now the paper was shown that permissive cardiotoxicity in that. So I wanted to ask all the three cardiologists at this particular point of time, asymptomatic patient, would you advise about the beta blocker and ACE inhibitors? In asymptomatic patient also you would start that.
Yeah, ACE inhibitor, beta blocker, definitely.
ACE inhibitor, beta
No,
blocker.
we are supposed to treat all 4 pillars of heart failure suggested by ESC in this patient and continue therapy which cures cancer.
Yeah, in
It's
symptomatic
not the
heart failure,
It's
sir.
not the cardiologist to decide to stop therapy. It's just cardiologist is supposed to support cancer therapy which will cure cancer.
Yeah, sir, four
So
pillars
these
are
pillars
only for symptomatic heart failure.
No.
We are
but
talking about
we are
asymptomatic.
Yes, but we are giving a drug which is again going to cause more LV dysfunction. And LV dysfunction is perpetual condition and there is no return. Even if you use all the pillars of heart failure, at the end of 10 years, all of them will fail. So there's nothing like really, but this drug is not to cure. So cure cancer. You may have a patient with LV dysfunction, treat LV dysfunction.
So there is a lot of
Continue
scope
treatment.
for India-centric publications now.
Sir,
Yeah,
Pandey sir, since you have a mic, what is your take on this top 2 new biomarkers? There are a lot of, 2025 I came across 5 to 6 papers on this.
Yeah, ST2 we have been using, and Galactin-3 is supposed to be the best one out of all the 3.
Okay.
NT-Pro, BNP, ST2 and Galactin. Galactin is
So this particular patient, sir, would you
most
advise
important.
before starting beta blocker and ACE inhibitors, okay, let's do ST2, SST2 or Galactin-3 marker?
So in asymptomatic LV dysfunction, we do a parametric imaging. Either you do a combination of biomarker or you do a T2 imaging looking at the ECV and transit time. So it has to be parametric, can't be based on just 10% drop in
Just
EF.
out of my curiosity, the way we have liver function tests which covers bilirubin, protein, SGOT, PT, SAP, do we have any lab giving cardiac biomarker which covers all these? No.
Two things is available. LALPath does ST2 and NT-Pro BNP. Galactin is still in research phase.
Okay. Yes, sir. I can hear you, sir, but I think your mic is not working. Yes, sir, mic.
See, when we talk about this 10% drop, it's not exactly 10% drop in EF. It's 10% point.
Correct.
So 55 to 45 or 47 to 37. So it's not 10%. Whereas when we are talking about GLS, it's a 15% from the baseline. So this shouldn't be confused. Yeah.
Perfect. I think, sir, last 20 years, for us, ejection fraction is like bread and butter for deciding trastuzumab, but we are moving away slowly further from that. This particular patient, we did not start beta blocker, ACE inhibitors. I felt that this particular patient was absolutely fine. We skipped one dose. Echo after that picked up from 50 to 54% from 3 different cardiologists. We started trastuzumab, Phesgo again. Echo before each dose for next 4 doses of Phesgo, normal, and we did not do anything. I don't know we did the right thing. Should we have started ACE inhibitors or beta blockers? That was there. And this particular paper, which was presented earlier, showed that if you give ACE inhibit cardioprotective medications in combination, there is very, very little cardiac death. And dapagliflozin is phase 3 trials have started. We will come to know about that. So protocols are there for asymptomatic patients, and there are good papers on that. This is something which I came across, and what I did was went back and did card talks of all 3 patients, and it found that it was helpful. Now retrospectively, I could say it was helpful. The last paper in last 2 minutes is low risk. Cardiac safety of reduced cardiotoxicity surveillance during HER2 targeted therapy. And this was, I think, presented by Dr. Niyanti, you? No, the low risk was presented. So in that low risk paper, what they said, can we reduce the cardiac surveillance? Okay. So let me ask Dr. Partha Roy. We are doing 3 monthly right now in asymptomatic patients. Would you reduce that in any particular subset of
Yes,
patients?
in especially
Dr.
when you are
Munna
going.
Das sitting beside you would say, "Kya बार-बार 3-3 महीने में echo कर रहे हो यार?"
When we are especially going away of anthracycline-based regimens, particularly when we are using both pertuzumab, trastuzumab, in that scenario, especially patient does not have personal history of any cardiac
So in
disorders.
anthracycline, you would
Yes,
not
yes,
deviate
yes,
from
yes,
this thing,
yes.
but assuming patient has not taken anthracycline, would you reduce your duration of surveillance?
Yes, it can be done. It can be.
Dr.
Provided,
Nihanti?
provided patient does not have any personal history of.
Frequency, sorry. Dr. Nihanti?
Sir, I may be wrong, please do correct, sir, because when I was reading this, they do say that if patient is not in risk, even a 6 monthly cardiac surveillance is acceptable.
I'm asking that only.
So-
because so far I am not doing 6
Like,
monthly.
yeah.
Any of the audiences, because in trastuzumab we are doing 3 monthly. मैं तो patient को बोलता हूँ calendar में 3-3 महीना डाल देना और आ जाना मेरे पास. This is what we normally tell. So this particular patient, Dr. Niyanti is right. They took 3 main, no cardiac illness of whatsoever kind, no diabetes and no hypertension. And they did 6 monthly, and they found that 0 patient developed symptomatic cardiac event and 1 developed asymptomatic drop in LVF. So I think we can adopt this particular, it's a possibility of reduced surveillance. All CDK4/6 inhibitors are cardiotoxic. This is, please remember that trastuzumab still remains the most cardiotoxic. Reduced surveillance is a possibility. With that, my time is also up, and I close the panel. If any of the panelists have any comments, we can take that.
Sir, I have one query to ask. I'm so sorry, sir.
Go ahead.
Sir, it's the same, sir. If a patient is low risk, upfront patient was not symptomatic, but if there is a drop, can we prophylactically start? Because currently we do
Yes,
have
that is-
ASCO guidelines of ARB inhibitors
That
in
is
that.
what sir is saying, and that is what the safe permissible paper showed, the meta-analysis of 8 papers, that if there is a drop of more than 10%, you start with ACE inhibitors or beta blockers or combination of both, and you have a permissible cardiotoxicity comparable to someone who does not have a drop.
Sir, and there's one more take also, you need not stop your oncological intervention also, it's mentioned. So are we right in continuing the oncological care?
I showed those slides. There are 7 criteria of continuing trastuzumab in asymptomatic patient with drop in LVEF. In that they have said there is no other comorbidities, patient is asymptomatic, BP is well controlled, 130/80 is what they have written. You have started on ACE inhibitors and beta blockers, and you are monitoring symptoms properly, you can continue trastuzumab.
Can I just make a comment? If
Yes,
that's
sir.
okay?
Sir,
Now is over to Vivek. Mera time ho gaya now. Whenever Vivek permits, we can continue.
Just a comment.
Yes, so just the comments. I think
last by Arjun.
Okay.
Yeah, so I just wanted to say, so one of the speakers did show one of my studies, the HER-SAFE study.
HER-SAFE
So
study.
we are actually looking at something very similar for the metastatic patients on long-term Herceptin. How long do we do the echocardiography? So we are also looking at 6 monthly echocardiography, so our results should be out soon. But again, we're seeing very similar data that the patients are actually doing reasonably okay. So maybe we can push out the duration of the
Absolutely.
interval.
Very good to know. Ma'am, the
So
last.
yeah, so in our clinical practice at TMH, am I audible?
You're absolutely
Yeah.
audible, ma'am.
So suppose like in this particular case, the EF drops to 50%, we do not stop. I mean, we tell the oncologist to continue the therapy. And as Dr. Gopal said, we start with the cardioprotective agents. If the and basically, if it's a low risk patient and patient is asymptomatic, go as much as you can. Like we have even rechallenged patients with 45%. If they're asymptomatic, give them the therapy and monitor. We don't monitor every month, every cycle. We do it every 2 months.
55% to 45% is more than 20% drop. You still tell them to continue.
55 to 45 is 10.
10% if you say, but it is a 10% drop. But if you say
it is the absolute 10% drop. Please, there is some confusion there. It is an absolute 10% drop. When we talk in terms of GLS, when we say 15%, it is from 18, 15% of 18.
GLS
but
is different.
EF is 10% is absolute value. And if it is even up to 45, if patient is asymptomatic, we support them with the therapy. In fact, patients with IHD who are 40%, old MI, we have even, patients have been treated with trastuzumab with robust GDLT.
There are papers of what you are saying, but from 55 to 45% drop, I think...
EF is not a problem, sir. EF is not a problem at all.
20%.
I think
it's a 10-point drop. Let's see.
It is a
10-point drop in EF, 15% drop in GLS. So there is a percentage, and here is the point.
Yeah. So it's always the percent. Absolutely.
Okay, perfect. Thank you so much. Thank you.
Thank you.